Let's go ahead and get started. This is the third in the series of what I call the fair game questions for your boards. And just one thing I want you to think about for anything that you're going to answer, for you all that are going to be taking your board soon or for even your in-service exams. All of these questions, whether it be oral or written, basically have three components. You have to read it to define the problem. You have to read it to define the treatment of the problem. And you have to read it to define the alternatives to the treatment to the problem. Okay? The issue that arises when taking exams is everybody jumps to alternatives. And what you have to train yourself to do is basically say, okay, the problem is X. I'm choosing this treatment because there's really never one absolute answer. And then be ready to defend that answer and then know the alternatives in case the examiner gets cranky. And if you can break it down into that manner, then it's going to be extremely easy. Rather than memorizing a bunch of stuff and then, oh my God, which one do they want now, you know? So you have to be quite logical with this stuff. Today I'm going to be covering achalasia. And the problem with achalasia is very well defined. The treatment is very well defined, even though you have multiple specialties trying to collect a lot of money on it. And the alternatives are well defined. Okay? And that's what I'm going to bring out. Now, the definition is basically achalasia is a motility disorder, obviously of the esophagus. And what happens is that it doesn't initiate with the absence of peristalsis. Actually, it initiates with failure of relaxation of the lower esophageal sphincter. As that becomes worse, then the normal motility of the esophagus begins to deteriorate, and then you get the motility disorder. It's not the other way around. There are entities where the motility disorder begins first, and that's what you have to be careful about when you approach a patient who they send to you for dysphagia, and you're working them up, and somebody says they need a Heller. That's your call. You have to decide whether they need a Heller or not. So the cause of the obstruction is always at the level of the GE junction for a true achalasia. It's mainly common in adults. Rarely do you see it in kids. It's actually in the much older age range. And in the older age range, you also then have to basically eliminate malignancy. Now, you need to have a little appreciation of anatomy in order to understand the pathophysiology that you're dealing with. Because whether you like it or not, all of surgery is based on pathophysiology. It's not based on pure mechanics. And so what you have is you have this muscle layer, and you both have longitudinal and circular muscles. And what happens at the GE junction is that these things basically hypertrophy. You know, they've just had a lot of exercise over time, and so they get tight. And that's what happens. And so, as you see that, these layers get tighter and tighter and tighter, and your opening gets smaller and smaller and smaller, and then they won't relax. So the treatment is based on how can I get this thing to relax. And as I said, now there have been multiple strategies that have been propagated, and each have their place. I'm not putting them down, but you have to understand when they should be done, when they should be offered, and that ultimately the surgical intervention is actually the cure. What you have is an increased lower esophageal pressure, sphincter pressure, then you get the absence of peristalsis, and then the LES doesn't relax in response to swallowing, and so how do these people present? What's the pathognomonic sign for achalasia? It's not reflux. Huh? Well, it can be retrosternal pain, but the classic is the elderly person who comes in and says, Doc, I wake up in the morning and my pillow is soiled. Okay? They're at the point where they don't feel the reflux, they don't feel the pain. The pathology has been progressive, so they have gradually decreased their diet through the years, literally. So they come in, they've lost weight because they know they're not eating. Well, they can't swallow, so the way they fix the swallowing is they stop eating. And so then, really at the severe achalasia, they come in and they're complaining that they soil their pillow. And what it is it's retained food in the esophagus, and when you lay down, gravity takes over and it just comes up. The cause is unknown. It's felt to be secondary to degeneration of the myenteric plexus, but again, that's theoretical. What happens is the neurons that allow the relaxation basically are gone, and when you biopsy them, you actually can see loss of neurons. And then the LES doesn't relax, and then the distal esophagus just can't move normally. The signs and symptoms, first, they'll begin with a progressive dysphagia. Solids more than liquids to begin with. They will then get this retrosternal pain induced by swallowing. As it progresses, then you get regurgitation of undigested food. They may or may not have reflux symptoms. They'll have symptoms of food sticking in the lower esophagus, nocturnal cough that's new onset, recurrent aspiration, pneumonia, and weight loss. Now, these all mimic the signs of esophageal cancer. And so you do have to keep that in mind when you're making the diagnosis. How they're evaluated, basically history and physical. Then you get a chest x-ray and you see this, which is just retained food in the esophagus, and you will see air fluid levels in the esophagus. The key as to whether it's a carcinoma versus an achalasia is that generally by the time you see this, the esophagus is severely dilated. Whereas in esophageal cancer, you won't see that. The esophageal cancer progresses quickly enough that you'll see maybe retained fluid, maybe not, but the actual size of the esophagus remains normal. Barium swallow still has a place, and this is pathognomonic. Large esophagus, aperistaltic esophagus, bird's beak, versus apple core. So if you see a normal esophagus with this, or a normal size esophagus with this, it's more than likely not achalasia. Okay. If you see a large esophagus with this, then you pretty well can say, okay, I'm more than likely dealing with an achalasia. Esophageal cancer is still an apple core lesion. Okay. But the key is the size of the esophagus. You must endoscope these people because you need to exclude malignancy. So, chest x-ray, history and physical chest x-ray, barium swallow, scope them. Or scope them, barium swallow. Usually get the barium swallows first. What you want to do is try and pass the scope beyond the obstruction. So if you can't do it with a regular size scope, switch to a pediatric. And you want to do 4-quadrant biopsies. Even if you cannot pass the scope beyond the lesion, go ahead and get your 4-quadrant biopsy above the lesion. If it's a carcinoma, it'll show up. Manometry is mandatory, not optional. You must be sure that you are dealing with a lower esophageal sphincter problem. Otherwise, there's a whole series of esophageal dysmotility pathology that can be confused with achalasia, and that when you go in and do a myotomy, the patient will not improve. So manometry is absolutely vital. One of the most common ones is diffuse esophageal spasm. It's generally associated with other disease processes, mainly autoimmune diseases, scleroderma being one of them. So the history will clue you in, but you do have to have a little bit of medical background to understand the other disease processes that can cause esophageal dysmotility disorders. The other one is a nutcracker esophagus. Okay, now a nutcracker can be improved with myotomy. That's a different story, but you have to have these measurements. I put this in for you to look at it, and you have it in the slides that I gave you. The way you're going to see a manometry picture on your in-service for sure. And the way I remember it, I can't memorize all of them, and I refuse to. I mean, I'm not a gastroenterologist. But the way I remember them is that it'll be a series of pictures like this. And what you'll see in a normal esophagus is you'll see a series of blips as you go down the esophagus. And then when you get to the lower esophageal sphincter, that blip is going to be taller than all the rest of them. And that's the way I remember achalasia. If you have a nutcracker esophagus, the pressures are inordinately high all the way down. And that's just basically the difference. The rest of them you don't need to worry about. You have 4 treatment options for achalasia. The first one is pharmacological. Then they can dilate them. You can use botulinum toxin. The ultimate cure is myotomy. And I left one treatment out on this slide because I'm going to go over it at the end. You can try calcium channel blockers and nitrates. These are all muscle relaxants. They basically give short-term relief. Clearly, there's side effects to these drugs. Are they curative? No. Okay, when do you use them? People who either are early in their symptom course, don't want an operation, can't tolerate an operation, or are too old. Okay? Normally, the gastroenterologist gets a hold of these people before we ever do, so everybody gets dilated. I mean, everybody. Because the train for the patient is patient to primary care to gastroenterologist, and then when everything else has been exhausted, they get to you. What happens with dilatation is that it basically tears the lower esophageal sphincter. They stick a bougie down, it's progressive, or they can use pneumatic, and it just rips the muscle. It's an internal tear. Hopefully it's not a through and through tear. The process is repetitive, so it's done every so often. What happens is it's a temporizing measure so that they'll dilate every year, then they'll dilate every 6 months, then they'll dilate every 3 months, and then somebody's going to get sick of it, so either the patient's going to get tired of it or the gastroenterologist is going to get tired of it, and then you're going to get the referral. The risk of perforation is about 3 to 5%. Like anything else, it depends on who is doing it. Botulinum toxin is a relatively new treatment. I say relatively new, past 10, 15 years. Basically, again, a technology looking for a disease. So if it works for wrinkles, let's try it on everything else under the sun. And so it's injected into the LES using the endoscope. It will temporarily cause local relaxation and is effective about 90% of the time. The problem is it's temporary. Again, you're not fixing the pathology. The pathology is a hypertrophic LES. Okay? And of course, there are side effects. The cure is a Heller. Pure and simple. You incise the muscle, it spreads, the sphincter relaxes. What it is it's a controlled incision, and the success rate is up to 90% if you have the right diagnosis. Now, on your boards, this is the other key point of this. They're going to ask you, how do you do a Heller? So how do you do a Heller? Chiefs? Anybody? Huh? How long on the summit? It's 3, right. That's the key number. Okay, it's 3. No, some people. No, some people. The answer is 3, okay? Some people do a lot of things, okay? Just remember, I'm trying to get rid of the noise. The answer is 3, onto the stomach. So it's generally done through the abdomen. Some people do it through the chest, okay? But it's generally done through the abdomen. If you choose to answer doing it through the chest, that's okay. It can be done either way. It can be done either laparoscopically or open. Please remember for your boards that making an incision is not a crime, okay? Making a big incision is not a crime. You do not have to do everything laparoscopically. You begin at 3 centimeters below the GE junction. It has to be 3 centimeters onto the stomach. That's what they all look for. You can make it longer if you want to, but you have to say that number. The muscle fibers are divided, and it's carried up onto the esophagus about 6 to 8 centimeters. Okay? The most difficult area of dissection is the dissection onto the stomach because the muscle bands are not very well defined. And so that's where your greatest risk of perforation is. And the other wrinkle to the question they would ask you on an achalasia is, well, doctor, how are you going to test for a perforation? So, Nick, how do you test for a perforation intraoperatively?
Air from above, water in the belly.
That's fine. Water, air, methylene blue, whatever. Anything, any permutation. But the key is you have the anesthesiologist pass the NG tube while you're there, and you test for it in the operating room. You don't wait till you get out, because if you don't test for it in the operating room, they're going to come back at you and say, well, doctor, you finished the operation, and that same night the patient spikes a temperature and becomes hypotensive. Oh, crap, I missed a perforation, okay? So you want to test for leaks. Small perforations are easily repaired, okay? So if you have a small perf on the stomach side, just fix it. You don't have to do anything else. The other wrinkle on this question that they ask is, okay, doctor, you've perforated. You've recognized the perforation when you've done the procedure. And hopefully they will tell you how big it is, and it's relatively large. So, Dr. Sith, what would you do?
So, essentially you still need to fix the perforation.
Right.
So, sometimes you can, I guess you can't repair primarily if it's too large. You can try to close up that part with either like a crayon patch or something, and then come back and do like you can redo the Heller myotomy on the posterior side, I guess, of the esophagus.
Right, you don't come back. You can do it at the same setting. But the key there is fix it 180 degrees, redo it. Okay? Don't worry, they're not going to tell you you perforated the other side. Okay? They want to understand that you know what to do in that setting. They're not going to make it that complicated, although you can perforate the other side. And then fundoplication is plus minus. Most people will do a fundoplication with it. Okay. Again, if you choose to answer the question with a fundoplication, that is correct, but choose one that you are familiar with doing. So most people do a Nissen. A Nissen is fine. If you go to review courses, you're going to hear people, well, I do a Collis, and I do this, and this guy did this, and don't, no. Tune it out. Just tune it out. Pick one you can do, one you know how to do. They all work, so that you can explain it yourself. Okay? There is a role for esophagectomy, and that is the last treatment. Okay? But you have to understand, if you're proposing esophagectomy, you're proposing esophagectomy for benign disease. And basically, the esophagectomy is indicated when the esophagus is totally non-functional. There's no peristalsis in it. It's just basically this solid, hollow tube. You're going to have problems with reflux, and it's hugely enlarged. What happens is even if you go in and do a myotomy with an anti-reflux procedure, the anti-reflux procedure doesn't work. The symptoms are still there. The patient still develop recurrent aspiration pneumonia. So if the esophagus has no motility, you are perfectly justified in recommending esophagectomy. Okay? It is the recognized treatment for this problem. If you do a myotomy in this setting, what you get is uncontrolled reflux even with a fundoplication. And oftentimes, if you answer the question correctly all the way along, they're going to maybe push you and say, okay, well, you have a patient who's referred who had a Heller myotomy and had a Nissen with it, and they still have symptoms of achalasia. What do you do? So Derek, what would you do?
I would get a contrast study to look at what was done, and then I would get a manometry to see if
Start from the beginning. Exactly right. Just start your workup all the way from the beginning. What you'll find is that you probably have an aperistaltic esophagus. They did the wrong operation. They probably should have done an esophagectomy to begin with. So what you do, prove your diagnosis, and then to fix it, you take down the Nissen, you do the esophagectomy, and then you reconstruct with whatever you have. So in summary, you have an anatomical disorder, tight LES, which causes a secondary motility disorder. It's not the other way around, okay? You must do manometry in these patients. Absolutely must. The myotomy needs to be carried 3 centimeters onto the stomach. Fundoplication is optional. I say optional. When you answer your question, do one, okay? And you must test for perforation intraoperatively. If it occurs, fix it, redo the Heller at 180 degrees. That's it. Questions?